All right, we just got through the low back. So this is the cervical spine. This is the neck. It's different. The neck has kind of a different feel to it, a different way of moving, twisting, bending, and that sort of thing. You do this, right? That, right? That. Can't do that with the lumbar spine. And that's relying on these facets, right? Facet, 3-joint complex. I have neck pain. That's a diagnosis, right? No, it's a symptom. Diagnosis is degenerative spinal disease, or that catch-all phrase, spondylosis, which is an umbrella term. It really doesn't mean much. But once again, disc, joints. It does look different. You're right. This bone right here, called the vertebral body, that bone right there, vertebral body, in the lumbar spine, it's more kind of ovoid, roundish. In the cervical spine, it's kind of a cube. So the way things happen are different here. You have this ligament that goes down the lumbar spine called the posterior longitudinal ligament. It's kind of weak, but that's why the disc will push in the back easier, whereas in the cervical region, that ligament pretty firm, so everything wants to go sideways. So you tend to have more neuroforaminal encroachment right here around the nerve. You tend to have a different kind of problem. But the facet joint's the same thing. I can't move, I can't twist. This stuff right here, the suprascapular stuff above the scapula, that's probably from your neck. That's probably from the facet. If it goes back here, everybody says, I need a thoracic MRI. No, it's like a referred pain. There's different places that you hurt depending on whatever the level is. 2, 3, 4, 5, 6, 7. It's been pretty well mapped out. And yes, there's little nerves right there. There's sensory nerves, nuisance nerves. Those nuisance nerves, once again, can be ablated. We can get rid of a lot of this nuisance pain. Now, if you have surgery and they put a little plate in the front, this is the front, and they put a little plate there, everything above and below the plate takes added biomechanical stress. And so we can get to that, block it. If we get a good result with local anesthetic, it's a roadmap for us. We might be able to go in there and cauterize those nerves. Well, it's a bad term, but just like we did in the lumbar region, it's the medial branch. So you're aware, 3-joint complex here, just like 3-joint complex here. What we try to do is diagnose the pain based on what you tell us, history, physical, medical decision making, and we take it to the next level and we compare it to the studies, we compare it to the physical findings, we try to put it all together and come to conclusions so that we can help you. So we talked about doing a lumbar epidural, interlaminar block. You can do it here in the cervical spine too. It's pretty tight though, right? So we do it with that x-ray machine. That x-ray machine shows us what to do. In my training, I learned without an x-ray machine. It dates me a little bit. I mean, this stuff's got to be done with x-ray. If it's being done without x-ray, rethink it. So we're going to talk about treatment options and limitations in the future, but right now, understanding why you hurt and what can hurt makes all the difference. This is not as much weight bearing. You got this little coconut on your head sitting here making about 11 pounds of force here. Very different than right down here where you got the tire pushing down on all these weight-bearing joints. Very different. So you tend to have a different kind of pain up here than you do here. The radicular pain or the pain down your arm can be there. You can have weakness in your arm. You may need nerve studies. Again, another test. But what we're doing is we're trying to figure out why you hurt to do the right thing for the right reasons. That's a good start.